all eminent faculty members and participants who have joined from various parts of India and abroad. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our chief guest, Dr. Chepsy Philip, guest speaker, Dr. Nihar Desai, all discussants and participants to this virtual symposium on the story of Venetoclax from bench to bedside. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this continuous medical education series under the aegis of Mumbai Hematology Group, Dr. M.B. Agarwal. Sir is Professor and Head Department of Hematology, Bombay Hospital Institute of Medical Sciences, Mumbai. He is also associated with other esteemed institutes as well, like PD Hinduja Hospital, Leelavati Hospital, Fortis Hospital, and Breach Candy Hospital in Mumbai. He is the president of Mumbai Hematology Group as well. I request Dr. M.B. Agarwal to navigate this program further. Sir, over to you.
Thank you so much, Mr. Sumit, and good morning to everybody from India. Good afternoon, good evening to the rest of the people from different parts of the world. Today, our guest speaker is Dr. Nihar Desai from Mumbai. He's going to speak to us on the story of Venetoclax from bench to bedside. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, and I've been extremely grateful to Zydus for supporting our webinars regularly every month around the clock. Managed by Perfect Square, once again, extremely competent in managing our webinars. So we thank Mr. Ashish Kumar, Mr. Sumit Madan and the team from Zydus, so Yash, Mr. Kalpesh and the team from Perfect Square, the Executive Committee of Mumbai Hematology Group, and of course our chief guest today, Dr. Chepsy Philip from Tiruvalla, Kerala, our guest speaker, Dr. Nihar Desai, all the discussants who are themselves eminent hematologists or medical oncologists from India and Myanmar. You participants for sparing your Sunday morning, afternoon, or evening. Next weekend, Saturday, at 7 p.m. Indian Standard Time, we have Dr. Anjali Advani from Cleveland Clinic, Ohio, speaking to us on managing adult acute lymphoblastic leukemia. And next Sunday morning at 11:30 a.m. Indian Standard Time, we have Dr. Karthik Ramasahi from Oxford, UK, speaking to us on Castleman disease and update. Discussants today are put up here alphabetically. I'll briefly introduce them to you. Dr. Aniket Mohite from Jahangir Hospital, Pune. Dr. Ayan Bhattacharya from Regional Cancer Center, Cooch Behar. Dr. Dinesh Sheikh from Mangalore Institute of Oncology, Mangaluru. Dr. Nin Mia Thanda from North Okkalapa General Hospital, Myanmar. Dr. Kunal Goyal from Tata Memorial Hospital, Varanasi. Dr. Monica Chennareddy from Vaidehi Hospital Research Center, Bangalore. Dr. Pujita Baireddy from Care Hospital, Banjara Hills, Hyderabad. Dr. Rajakumar Ramaswamy from Velamal Specialty Hospital, Madurai. Dr. Ramesh Balasubramaniam from Meenakshi Mission Hospital and Research Center, Madurai. Dr. Ravi Kiran Bonanthaya from Hassan Institute of Medical Sciences, Hassan. Dr. Sushil Sevarajan from Department of Hematology, CMC Vellore. Dr. Yashwant Kashyap from All India Institute of Medical Sciences, Raipur. Dr. Yi Moon Thant from North Okkalapa General Teaching Hospital, Myanmar. Dr. Yoga Lakshmi from Care Hospital, Hyderabad. Our guest speaker for the day is Dr. Nihar Desai, who is MD Medicine, DM Hematology, Assistant Professor in the Department of Hematology at Lokman Tilak Medical College and Lokman Tilak Municipal General Hospital, Sion, Mumbai. He did his internal medicine residency at LTMG Hospital Medical College, Mumbai. This was followed by DM in clinical hematology from SGPGI, Lucknow. He worked as assistant professor. He's working as assistant professor in hematology at LTM Medical College, Sion from 2022 till date. He's currently working as a BMT and cellular therapy fellow at the Princess Margaret Cancer Center, Toronto. He has a special interest in AML and care of geriatric patients with hematological malignancies. Outside of his work, he's a drummer and an avid wildlife photographer. Over to him to deliver his lecture, He will be delivering the lecture on the story of Venetoclax from bench to bedside. But prior to that, we have our chief guest, Dr. Chepsy Philip. Dr. Chepsy Philip is known to everybody. I'm just completing the formalities. I'm extremely grateful to him for sparing his time to inaugurate our webinar today. He's Senior Consultant and Program Director, Regional Advanced Center for Transplantation, Hematolymphoid Oncology, and Marrow Diseases from Believers Church Medical College Hospital, Tiruvalla. He is a clinical hematologist, hemato-oncologist, and transplant physician. He did his MBBS from CMC College and Hospital, Ludhiana, 2004. He then completed his MD in General Medicine from Baba Farid University of Health Sciences, 2010. He further completed his DM in clinical hematology from CMC Vellore from the Tamil Nadu Dr. MGR Medical University in 2014. He is the ASCO International Development and Education Award recipient in 2015. He has also undergone advanced training stem cell transplantation at the University of Washington and the Seattle Cancer Center Alliance. After serving as a faculty at the CMC College and Hospital, Ludhiana, he is now Professor and Program Director at the Regional Advanced Center for Transplantation, Hematolymphoid Oncology, and Marrow Diseases, Believers Church Medical College Hospital, Tiruvalla. His areas of interest include myeloid malignancies, thrombosis, and alternate donor transplantation. With this brief introduction, I invite our chief guest for the day to inaugurate our today's webinar and also say a few words of wisdom, especially for our junior colleagues. I'll stop here and over to Dr. Philip.
Thank you so much, sir, for those very kind words. It has been giants like you who have actually inspired interest in so many of us to pursue hematology. I personally know my fellow co-colleagues in hematology were totally inspired by your work to pick up hematology. And thank you for this opportunity and the regular CMEs that you keep on doing, which motivates so many of us to keep abreast in the field and also to explore the challenges. And I'm very happy to hear from Nihar today. And as much as hematology is exciting, it is even more exciting to have such young minds also pursue hematology with the passion. I follow his tweets. I see the work that he does. It's really impressive and very happy for the future of hematology. And I would really like to pass on my passion for hematology to all of those who are listening here, because whether you dream of becoming a researcher, a clinician, a lab technologist, or even a patient advocate, there is no other field which gives you a complete hands-on approach to entirety of this other than hematology, in my personal opinion, and nothing which rapidly translates from bench to bedside as much as hematology. And it's I think very exciting times in terms of progress that is happening, and there is so much happening in hematology. And by pursuing hematology, you also have to deal with a lot of challenges. You have to impact countless individuals. You have to go through them in their daily routine. You have to support children fighting leukemias, adults fighting other blood disorders. So even when you're at the forefront of many breakthroughs, you also have to personalize and tailor your approach according to your setting. So that really means that you have to be a champion for all your patients. So embracing hematology, I think, means embracing progress, and it is a life calling. And I really thank the Mumbai Hematology Group for this persistent webinars that you do. I learn a lot whenever I get time. I do log in. The field is rapidly evolving, and we need young, bright minds to further pursue research and make hematology even more sweeter and revolutionize the way we diagnose, treat, and prevent blood disorders. Thank you so much, sir, and thank you for this platform. Looking forward to more.
Thank you so much, Dr. Chepsy Philip. That was a wonderful speech to inaugurate this webinar. Such kind words. Extremely grateful to you. And you are absolutely right. The young brigade is fantastic. They have great mind. They have great inputs in the field. They have learned so much. They want to experiment so much. They want to deliver so much. And an example here is now our speaker, Dr. Nihar Desai. Over to you, Nihar.
Thank you so much, sir. I mean, this has been a real honor. I started off as listening to all the webinars during my training days at PGI. and then finally got invited as a discussant. I was really happy, and today I cannot even imagine and cannot even tell you how happy I am to be speaking on this platform. I mean, we've had so many great speakers here over the last couple of years that I've been listening to this MHG webinars. Even on YouTube, we always go back and listen to those webinars which have happened. And I'm truly honored, sir. Thank you so much for giving me the opportunity to speak about Venetoclax. I mean, that's a drug which is close to every hematologist's heart as of today. It's revolutionizing so many malignancies. And I mean, I read up a lot for this webinar. I hope to do justice to this amazing drug, which is helping patients in almost all fields of hematology. So if you permit me, I'd like to share my slides, sir.
Yeah, please go ahead, Nihar.
Thank you, sir. So are the slides visible?
Yes.
Right. So good morning, everyone. Thank you, dear participants and discussants, for joining us this Sunday and sparing your precious time. And I'm really, truly honored to speak about Venetoclax. So I'll share this PPT at the end of the discussion if anybody wants it on the email. But here we go. We'll start with the story of Venetoclax and how it progressed from bench and it's moved on to the bedside and helping patients almost everywhere. So sir has already given a brief introduction with his generous words. So I'm Dr. Nihar Desai. I'm currently the assistant professor of hematology at Lokmanya Tilak Medical College in Sion. And I'll just start with my talk now. So this is a brief overview of my talk. So I'll be speaking a bit about the apoptosis pathway, which is really critical in understanding how Venetoclax works and how the entire mechanism of action is. Then I'll speak a little bit about the early BH3 mimetics, which led to finally the discovery of Venetoclax, the breakthrough molecule. We'll discuss a bit about the early phase trials using Venetoclax and finally the landmark phase 3 trials for various malignancies which led to the approval. And then a little bit about the off-label uses of Venetoclax, which is for everything in hematology as of today. But then everything which is so golden has got to have some thorns in it, and that's the resistance mechanisms. And we'll speak very briefly about some pathways of resistance and how do we tackle them moving forward. So we all know these hallmarks of cancer. This was a great paper by Hanayan et al., which highlights this part here. So cancer, as we know, is like uncontrolled proliferation of cells. So that can happen by two mechanisms, either when the cells are proliferating in excess, or the second part of it, which is where we'll be speaking about today, that is evading apoptosis or reducing apoptosis. So by both of these mechanisms, we have increase in cell number, and that is what leads to tumor growth, which is what the entire term cancer is. We've targeted a lot of these hallmarks of cancer, and we've moved way forward. So we've got PARP inhibitors, we've got VEGF inhibitors, we've got tyrosine kinase inhibitors. But now we're speaking today about the pro-apoptotic agents, the BH3 mimetics or the BCL2 inhibitor, which is where they work here. So that is the resisting cell death part. So when we speak about resisting cell death, we need to speak about apoptosis. So this takes us all back to medical school, where we learned this classical pathway, and we have two arms of apoptosis, the intrinsic as well as the extrinsic. So when we speak about the extrinsic pathway, we are talking about the Fas ligand mediated cell death. But today we'll restrict ourselves to the intrinsic pathway. So we start at this point number 1. So whenever a cell is exposed to any apoptotic stimuli, be it in the form of nutrient deprivation, exposure to chemotherapy, exposure to any other ionizing radiation, one of two things happen. Either the cell will survive this, repair itself, or the cell will undergo death, which is apoptosis. So if the stimuli is too strong, wherein the cell survival pathways cannot kick in, what happens is that these BH3 activators, these red triangles that we see here, they overpower these Pac-Man-like figures here. And because of this overpowering, this happens. The pore forms here. Once the pore is formed in the mitochondria, we release all the mitochondrial contents. Finally, they form the apoptosome, and there is downstream activation of caspase. Thus, cell death occurs. But what cancer cells do is, they're smart. They have an upregulation of these pro-survival Pac-Man-like figures here that we see. So then these red triangles cannot overpower these pro-survival ones. And the further downstream activation of caspase and the outer membrane permeabilization, which is this MOMP, this doesn't happen. So the cell eventually survives. So what happened at the bench side was that BH3 only sensitizers or BH3 mimetics, we created more of these red triangles basically. So once we have more of these red triangles, what happens is that the overpowering of these Pac-Man-like figures is overcome by the excess of these red triangles. This is nothing but what Venetoclax does. This is the summary of its mechanism of action. It is basically a BH3 mimetic. So when we speak about these BH3 and these BCL2, what exactly is it? So it's a big family. So it's the big healthy family containing 18 members. So I've separated them out with this orange line. So when we have above here, this is a structural classification. It's very easy to decipher that these two are almost similar, but they differ significantly from this one below the line. So this is what the BH3 only proteins are. And these red ones are the pro-apoptotic ones. They are similar to the red triangles that we spoke about in the previous slide. Whereas these green ones are the pro-survival. So there is a constant battle going on between the two, and the winner takes it all. If the pro-survival overpowers the pro-apoptotic, the cell will definitely survive, and vice versa. The structural classification is important because since there is only one homology domain here, these proteins are known as BH3 only proteins. That is what the significance of only is here. And finally, whatever is overpowering it, be it the pro-survival or pro-apoptotic, eventually acts through these two proteins, BAC and BAX. It's important to remember this because eventually all of this talk will be reflected when we speak about Venetoclax's mechanism of action. What happens next? This is what happens. It's a constant tug of war, as I said. If the pro-apoptotic wins, there is cell death. Now, the next thing, if the pro-survival wins, then there is cell survival. And this is what happens in malignancies. So malignancies upregulate BCL2, BCLXL, and all these other proteins. Once they are upregulated, the cell will survive. And through BAX and BAC mediated, inhibition of BAX and BAC will happen. So these are the interactions. We have BCL2, these 5 proteins here that we see, BCL2, BCLXL, BCLW, MCL1, and BFL. These are all the pro-survival ones. They'll be inhibited by BAD, NOXA, or all of these proteins. So there's a constant war, as I said. So how did the journey of these drugs start? At the bench side, there were a few rules which were laid out for what is a true BH3 mimetic. So the true BH3 mimetic, its biological activity must only depend on BAX and BAC. It should not act via other alternate pathways of destruction. The binding affinity must be in the low nanomolar range. That means it should have high affinity binding to the target. The cytotoxic activity must correlate with the BCL2 protein family levels. And finally, when we treat with these drugs, certain relevant biomarkers should be triggered. Like BCLXL, we know is important for platelet survival and platelet maturation. If that is inhibited, thrombocytopenia would be the expected side effect. So we must know that if this is inhibited, thrombocytopenia is there, and that is what happens with one of Venetoclax's congeners, which is Navitoclax. We'll come to that. So we start the journey with this early BCL2 inhibitors. These are truly poor pharmacological properties. They had very poor drugs. They had poor pharmacological properties, and they did not even bind the BCL2 pocket correctly. So further, it was improved upon in the lab, and we got pan BH3 mimetics. What do? They inhibit these 5 proteins that we spoke about previously. And it's important to remember, they inhibit all 5. As we go further ahead, this box in red will keep becoming smaller, as you'll see in the next one. So we keep becoming more and more specific in our target. So anyways, these Obatoclax, Gossipol, Apogossipol, and these previous drugs, they were binding to all 5 pro-survival BCL2 proteins. But again, as we said, the affinity should be high, but these drugs did not offer that. They were killing BAX deficient cells as well as the wild type cells. And therefore, they had a lot of off-target effect and they lacked specificity at all. Then came the big breakthrough. As I said, this box is getting smaller with each passing slide. From 5, we've come down to 3 now. So they are BAD-like drugs because these 3 are inhibited by BAD here. So they mimic BAD and they bind these 3 proteins. That's what's written. And they do not bind to MCL1. So that can be a pathway of resistance. That's towards the end of the seminar. So another drawback was that because of BCL-XL inhibition, that thrombocytopenia we spoke about became dose limiting with Venetoclax and this ABT737. And there was also poor bioavailability with the previous drug, ABT737. You might ask, what is ABT? And that's because all these drugs were developed by Abbott. Then finally comes the hero of our talk today. And the box has gotten extremely small. It's a specific BCL2 inhibitor. So it's not inhibiting these 5. It's not inhibiting these 3. It's not a BAD-like drug. It's only a specific BCL2 inhibitor. And it acts and binds at 100 times more affinity than the rest of the 2. So it's quite specific. Therefore, this dose-limiting thrombocytopenia has gone away, which was a problem with the BCL-XL inhibitors. The binding affinity is high, therefore it becomes more specific, and it dissociates the BIM-BCL2 complex here, and it finally leads to cell apoptosis. So this is how Venetoclax finally came into being, and from ABT199, it got the name of Venetoclax. So what is the difference between Veneto and Navitoclax, the 2 important drugs that are still clinically used? So the problem with the BCL-XL inhibitor Navitoclax was the thrombocytopenia. So as you can see in this figure, at standard doses of Navitoclax of 200 and 250 mg, there's significant thrombocytopenia here. But the reduction in platelet lymphocytes is quite less. It's exactly the opposite with Venetoclax. And that was achieved only by replacing this indole moiety with an aza-indole moiety. I mean, hats off to the preclinical scientists who give us these amazing drugs to work with on our patients. And this is how Venetoclax came into the clinical picture. So as we speak about it, the selectivity, this is the one that we speak about today. Mechanism of action, already spoken about in brief. Eventually, there is outer membrane permeabilization because of this activation of BAX-BAC and downstream caspase activation leading to apoptosis. This was too beautiful a figure to be avoided. I know this slide is a little redundant, but I wanted to highlight this figure here. So next we ask ourselves this question: why aren't all malignancies susceptible to Venetoclax? I mean, there is evasion of apoptosis in everything, but there is a difference in dependence on BCL2 for survival. Not all the cells require BCL2 for survival. There are other microenvironment related factors which lead to proliferation of the malignancy, and the cell might not need only BCL2. So BCL2 inhibition will act partially, but might not be completely eradicating the malignancy like we see in DLBCL and AML, and they need combination therapy rather than single agent Venetoclax. And we also have some presence of extrinsic stressors. So when we add extrinsic stressors like chemotherapy or hypomethylating agents, then there is further betterment of action of Venetoclax. We've already seen that. This brings me to the classical figure, the bullseye versus the hammer strike effect. So the bullseye is when the cell is completely dependent on BCL2 for survival, and Venetoclax will obliterate the malignancy. And that we've seen in CLL, certain subsets of myeloma. Versus here, this is the one where Venetoclax will help, but it will not hit the bullseye. So there will be some additive effect with other chemotherapeutic agents, and that's where combination therapies have been useful, like in AML and sometimes in DLBCL as well. So that's the reason why everything is not universally susceptible to Venetoclax. A brief about the pharmacology, since we are speaking about bench to bedside, this is the bench part of it. So we all know it's an orally administered drug. This is the chemical formula. It looks beautiful. I don't understand much of it, to be honest. The maximum plasma concentration is achieved almost 5 to 8 hours post the dose. And the terminal half-life of the drug is 26 hours. It's a highly protein-bound drug, and it's almost completely excreted by the fecal route. The metabolism, we all are very well aware that it is by the CYP3A4, and we take advantage of this fact and reduce the Venetoclax dosing at times when combining with azoles or other CYP3A4 inhibitors. But the metabolism is, the metabolite is M27, and that is a much less active agent. So once it is metabolized, the activity of Venetoclax is gone. And this is a brief pharmacology of the drug. This beautiful experiment was done way back in 2016 by Salem et al. And they showed that Venetoclax between the area under curve of Venetoclax between a fasting meal and a low and high fat meal was compared. So the Cmax and the area under curve increases significantly, almost 3 to 4 times in the fed state versus the fasting state. So as of today, we all tell our patients to use Venetoclax after a breakfast or after any meal and not to take it empty stomach. So this is where this concept of using Venetoclax in this way originated from. There's good data for it. So coming to the big one now, the drug-drug interactions. So this is the pathway of metabolism. So we'll obviously speak about CYP3A4 inhibitors and inducers. So when the enzyme is inhibited, the area under curve is increased by 400% to almost 700%, depending on how strong the inhibitor is. So with moderate inhibitors, there is 400% increase. With strong inhibitors, almost 700% increase in the area under curve. With inducers, the effect is also pronounced. Moderate inducers reduce the area under curve, and strong inhibitors will reduce it by almost 80%. So what is the clinical implication? This was again studied beautifully by Salem et al. Just a year after the initial experiment. They gave Venetoclax monotherapy at 400 and 1200 milligram doses, and the area under curve was plotted. I made this orange box to highlight what is our target zone. Then they gave Venetoclax half the dose with a moderate inhibitor and 1/4 the dose with a strong inhibitor. What was the resultant effect? That all the area under curves remained in this box, just excluding some. And this is what the dosing implications came up to be. Based on this is the final thing that we do. When we combine Venetoclax with moderate CYP3A4 inhibitors like isavuconazole, fluconazole, atazanavir, we reduce the dose by 50%. With strong inhibitors like POSA and voriconazole, we are reducing by almost 75%. And so the final resultant dose that we get is from a 400 milligram standard dose to almost 200 milligrams when we combine with isavu or flucon, and 100 milligrams with vori or POSA. 75 is usually difficult to procure. We get standard 100 milligram tablets. So that is what we usually use, 1/4 the dose. And when we combine with inducers, there's no standard guideline. So this has significance in the Indian setup because, we frequently end up using rifampicin many a times in these patients, but it's best to avoid concomitant administration. So there's no guideline to say how we should use rifampicin with these drugs. It's best to avoid it. So now, once we know the pharmacology, we should know the approvals, because this is where the drug is approved by FDA, EMA, and all the licensing authorities. The first approval came in April 2016. This seems like recent, but in hematology terms, it's ancient. And it was approved for the first time as a single agent for patients with CLL or SLL with the deletion 17p in the refractory setting after they had failed at least one prior line of therapy. Couple of years later, when we had trial data from Murano trial, the combination with rituximab was approved for relapsed refractory CLL with or without deletion 17p. But then came the big monster, the big breakthrough. Finally, in newly diagnosed acute myeloid leukemia, we had an accelerated approval for elderly patients who are unfit for intensive chemotherapy. Finally, in May 2019, like all drugs from relapsed refractory setting, Venetoclax crept up into the upfront setting. The newly diagnosed CLL, SLL based on the CLL14 data that was in a combination with obinutuzumab. And then the final approval, which was from accelerated approval to a formal approval for newly diagnosed AML, came in October 2022. So barring this, we can see that single agent Venetoclax has been phased out. All the approvals are in combination. Only this approval was for single agent. And we'll see the reason why. So let's embark on this journey in CLL, because that's the place where maximum research and the longest data is. So if we see the NCCN guidelines today, they're confusing, but there is always Venetoclax. Again, I've put those orange boxes here. In frontline setting, we have Ven-Obin, we have Ven-Ritux in the relapse setting. If it's deletion non-17p or this below is for del 17p, everywhere Venetoclax is going to be used. The reason is clear, because Ven acts in a non-TP53 dependent manner. But then the question is, in CLL, what is better? And this is something which is beyond the scope of this seminar. We cannot get into this debate, BTK inhibitors versus Venetoclax combinations. But these are few salient points. Venetoclax, there are few disadvantages and advantages. So venetoclax needs monitoring for tumor lysis syndrome, which is sometimes required to be in the inpatient setting. And the monoclonals which are combined with it are usually intravenous, and it's difficult to give. There is significant neutropenia, sometimes infectious complications, even deaths. Deaths due to TLS are now fortunately rare. And those are some of the side effects or some of the drawbacks, I would say. But what is the advantage? The biggest advantage is this: it's a time-limited therapy. When we give BTK inhibitors, we are talking about lifelong therapy and its antecedent attendant complications like, ibrutinib causing cardiac toxicity and a lot of other complications, atrial fibrillations, etc. But that is not the issue here. But there is one drawback. When we're using for TP53 mutated patients, there has been a lack of durable remission. The word being durable, there will be response. It will be, partially durable, but long-term durable remissions are rare in this patient spectrum. So what is the best ideal treatment for these patients with P53? If you ask the experts today, they say that continuous BTK inhibitors, especially with safer second and third generation, are preferred. But that's up for debate. Another USP of venetoclax is this undetectable MRD rate. When we use with combinations, we are getting undetectable MRDs of almost 50 to 60%, which is almost unheard of with single agent BTK inhibitors. Anyway, we'll move ahead and speak about the TP53 status not affecting the responses. We have already said the response is TP53 independent. And there will be, as was seen in this experiment by Anderson et al., that venetoclax will induce rapid onset apoptosis in vitro and in vivo, and that will be independent of P53 function. But despite this, it remains a prognostic factor for survival. So we have not been able to negate or neutralize the negative effect of this mutation as of today. The durability of response in any malignancy most of the times depends on the depth of response. We've seen this and heard a lot of chatter about myeloma as well, even about AML, and obviously it is mainline in ALL. But the deeper the response, the more durable it is. So here are the durabilities stratified by MRD, and here according to classical CR, PR, or non-response. Obviously CRs do better than PRs and others, and undetectable MRD does much better. And as we said, venetoclax has a great ability to get patients to this state of undetectable MRD. So that is going to give you deep responses. So we first start with this original phase 1 study, which was there. And this is what led and kicked off everything here. So this was for a relapsed refractory patient population, 3 median lines of therapy, a lot of patients with high-risk genetics, as you expect in this phase 1 study. Small numbers, 116, which is quite not so small for a phase 1. And the overall response rate was astounding, 79%. And even in patients with DEL 17P, who had not much better, this is way back in 2015. So this is early times for BTK inhibitors as well. So the overall response rate, a lot of patients were not even getting BTK inhibitors. This was the chemotherapy era was still ongoing. So 71% for those patients, 20% CRs, and undetectable bone marrow MRDs were 15%. So this was unheard of results for some time back in 2015, which is 8 years from today. But again, there were issues with neutropenia, almost 40% with grade 3, grade 4 neutropenia. And the 15-month progression-free survival, almost 70% at a 400 milligram dose. So based on this, the best efficacy and the least toxicity, 400 milligram was the recommended phase 2 dose. Here we can see slight separation of curves at 24, 30 months with and without 17P, which is what I have alluded to in the past, that the responses are good somewhere here, and then gradually these patients do relapse. So this phase 1 study led to the second combination study now of venetoclax with rituximab in a phase 1B manner. And this was again with 2 previous lines of therapy, 70% IGH unmutated, 20% deletion 17P patients. We used 400 milligram dose, which was the recommended phase 2 dose. And you can see here, the CRs went up from 20% to almost more than double, which is 51%. So the combination was safe, well tolerated. And the grade 3, grade 4 neutropenia has not increased. It was 50, 51%. Here also it's almost 50%. So the grade 3 neutropenia, we learned also to better manage it. And also the ramp up, which is now the standard of care, was introduced for the first time in this trial. So the tumor lysis syndrome led to a few deaths, and because of which we today ramp up the venetoclax like we do. So post this successful phase 1b study, we'll jump right into the phase 3, the Murano trial, which is, I'm sure everybody is aware of this. So it was a R Venetoclax versus R Benda in relapse refractory CLL. Important to know that this trial accrued much before these drugs were clearly available. So R Benda was quite okay as the standard. So this was R Venetoclax for 6 cycles, followed by a Venetoclax monotherapy for a total of 2 years, compared with R-bendamustine, the standard way we give it, for a total of 6 cycles. So this was 6 months, followed by up to 2 years. So this is the main study. The crossover was not permitted in this part, the main study, but in the sub-study, subsequent retreatment with venrituximab was permitted for these trial patients. This is something which is exceptionally good to see. The wider the curve separation, the better we feel, and the better we expect our patients to do. So this phase 3 study, large number of patients, again, similar spectrum, 70% unmutated, 20 to 30% with a P53 aberration. The 2-year PFS is so significantly different between the two, you can almost drive cars past them. 2-year PFS, 85% versus 2-year PFS of 36%, 80% better compared to the standard of care at that time. For Del 17p patients also, the response was not bad. In fact, it was, the hazard ratio was so much better because we know that R-Benda is a poor choice for them. The median PFS for this population here we see was not reached for Venetoclax arm versus 17 months here. And the 2-year overall survival was almost 92 versus 87%. The more important part again.
Hello?
Hello? Am I audible, sir?
You are audible. Continue.
Yeah. The more important part here, as we've seen, the MRDs are something that we chase. Look at the numbers of the part which is in green here versus here. We see significantly greener pastures here. And this is the assay negative. So this is when MRD is negative, and we attain significant MRD negativity with the venrituximab group. So we obviously knew on longer term follow-up, we'll get more better results. Look at the 4-year PFS. Still the car can drive through it. We still have good numbers here. And now we have numbers based on the MRD. When we see here, this is the undetectable MRD, low detectable versus highly detectable MRD. The undetectable MRD 18-month PFS is amazing, 90%. And the 4-year progression-free survival is still 57% here. And it's almost gone down to 0 for patients with R-Benda. And overall survival, we here start to see difference in OS as well. And for a malignancy like CLL, to be seeing an overall survival difference is quite huge. Again, we have further trial data from at 7 years. This is just follow-up, longer and longer follow-up. Look at the PFS here, still 20%. So 1/4 of these patients at 7 years are still free of survival, free of progression. And obviously it is not evaluable here in the R-Benda arm. And a 7-year overall survival of 70% for these patients. And they are all relapsed refractory CLL patients. So this is quite encouraging. And based on this, obviously the FDA approved our Venetoclax as a standard of care for these relapsed refractory patients. So what are our takeaways after 7 years of data analysis is that the progression-free survival, overall survival, undetectable MRD benefit, they're all sustained. And it's regardless of high-risk biomarkers. There are some differences between Del 17p and without Del 17p, but compared to R-Benda, our Venetoclax arm is superior in both. The time required for next treatment, TTNT, was much longer, and this was a fixed duration R-Venetoclax. It's a 2-year R-Venetoclax combination. The attainment of UMRD prolongs progression-free survival was shown in this trial. And again, the good part is that retreatment with venrituximab still remains a viable option, which was seen in the sub-study wherein crossover is permitted. So these are our key takeaways from the Murano. Again, we now know that there are 2 amazing drugs. So why not combine the 2? Also, when we have preclinical data about them acting synergistically. So how do they act synergistically? Ibrutinib targets the dividing population, whereas the resting subpopulation responds to Venetoclax. So it's like the 2-hit thing. We're not letting it live. We're targeting at both levels. So BTK inhibitors here are going to target the dividing population, and this is the resting population, both of them together. And we know that BCL2 inhibitors will inhibit just BCL2. So the rest of them will get upregulated. But fortunately, our BTK inhibitors are known to inhibit BCL-XL and MCL1. So there is synergy at multiple levels. And finally, we know that these two drugs act very well. And this was shown for the first time in the phase 2 Clarity study. This was an MRD-based endpoint in this trial. And if we see the violet here, the light violet versus the dark violet, this is where, low levels of MRD, MRD 4 and 5, highly, at 14th month. Why are we saying 14th month? Because it's a 12-month combination and 2 months of ibrutinib lead-in period. So at 14 months, that is when the treatment is completed, bone marrow MRDs are 36% negative here. This is at this time point. As we keep going further ahead here with prolonging follow-up, at 26th month, we have almost close to 40-45% patients who are undetectable MRD in the bone marrow, and peripheral blood is almost half of the patients don't have any detectable MRD. So these were good results. Again, if we tried it in the relapse setting, Dr. Jain said, why not do it in the frontline setting? And this was obviously including only patients who had high risk and high risk mutations and older patients who were unfit for other agents. And when an ibrutinib, we know it acts synergistically. So look at the CR rates here and the undetectable MRD in the frontline setting. There we were in the range of 30, 40, 50%. Here we are in the 60 to 70% zone. So earlier treatment also is safer. It's all oral and it leads to really deep responses. So this was in the NEJM 2019 paper by Dr. Jain. So this again was compared, the combination was compared to chlorambucil and obinutuzumab in a phase 3 study. I don't know why the control arm is chlorambucil plus obinutuzumab, because I failed to find a reason for that. But again, the separation with 12 cycles, and we've reduced the duration here. So in frontline setting, we are speaking of 12 months of combination. In the relapse refractory setting, based on Murano, we are thinking of 24 months of therapy. When we compared these two, again, huge differences in the progression-free survival curves here. So median progression-free survival is not reached versus 21 months. And the 2-year progression-free survival is here, 84 versus 44%. And it's quite sustained. Even at 30 months, we have almost 80% patients free of progression. So this crux was that an all oral fixed duration daily therapy is feasible in this patient population. This is an interesting trial. It had 2 cohorts, the MRD dependent cohort as well as a fixed duration cohort. Again, similar type of model, 3 cycles of lead-in ibrutinib followed by 12 months of combination. And then it was an MRD guided randomization. So it was not a phase 3 trial, but it randomized after a duration of therapy based upon the MRD. The primary endpoint was a 1-year disease-free survival. We'll not get into the nitty-gritties of the trial, but the crux was that in both the cohorts, the fixed duration and MRD driven, the rates of undetectable MRD are very high. After 12 months of both combination, we have almost peripheral blood, 3/4 of the patients being MRD negative. And in this MRD cohort, we noted that once you discontinue the BTK inhibitor after 12 months, there was not a significant drop-off in the progression-free survival. And this supported a time-limited treatment strategy. So this was a key takeaway from this trial, that continuing a BTK inhibitor after this fixed 12 cycles does not lead to any significant benefit, but just adds a little bit of side effect. So no point doing that. So time-limited treatment strategy was what was seen. And again, we see here the PFS was similar at 2 years at 95 versus 84%, not statistically different. So this is the summary, that slide which I've a table which I've created. We can see here this highlighted point is important. The 2-year progression-free survival for these patients almost is in the high 80s to 90s range. And this MD Anderson trial by Dr. Jain is important. It's in the frontline setting and in a high-risk population. And that 1.5-year progression-free survival, 2.5 years, is almost 93%. So that's quite a significant number. And that is only because we are attaining deeper responses. So the deeper responses are something that is the USP of Venetoclax. So the CLL14 trial now, the landmark trial which led to approval of CLL. Mind you, the ibrutinib combinations are not yet FDA approved, but combination with a monoclonal antibody like obinutuzumab is approved based on this trial. So this trial again assumes importance here. Big numbers, similar type of patient population, 60% IGHV unmutated. The 2-year progression-free survival, poles apart, chlorambucil obinutuzumab versus ven obinutuzumab. 3-year progression-free also better. The ORR and the CR as well as the undetectable MRDs. So much deeper responses here at end of treatment. And again, this is a fixed duration treatment that we are speaking about. And if you recollect from the first slides, the grade 3-4 neutropenias with rituximab and venetoclax in the Morano was also similar. And this is at 50%. So these are the differences in progression-free survival at 2 years. Further, when we move ahead, just look at these numbers in green, significantly better at all time points. And we have more and more follow-up now. This is the 6-year follow-up. And we know that now in a frontline setting, using obinutuzumab, which is a better monoclonal than rituximab, half the patients remain free of progression at 5 years of treatment cessation. So we're talking of 1 year of therapy, 5 years, no drugs for these patients, and we can expect half of them to be free of progression. And the best part is that the benefit is observed even in subgroups which are classically much difficult to treat. So this is definitely a winner here. We found ourselves a real good drug. Again, this trial, the 4-arm trial, it compared classical chemoimmunotherapy, our venetoclax, obinutuzumab venetoclax, and obinutuzumab venetoclax with ibrutinib. So the triplet that we speak about. So the final crux was that venetoclax combined with obinutuzumab is superior to chemotherapy and venetoclax combined with rituximab. So there was no significant difference between chemotherapy and rituximab when it came to the 3-year progression-free survival. So it established that ven is good, but ven is better with obinutuzumab. And this is the final crux of this trial. Then we move further ahead. Why not combine 3 active agents? Why not combine A plus V plus O? So BTK inhibitor, BCL2 inhibitor, and a monoclonal. Can be done, but maybe it's the future. And it can probably negate the poor PFS associated with del 17p. Why? Because look at these 2 curves here. All patients versus p53 aberrant. They almost look similar. So we've probably, in terms of responses, we have abbreviated the difference in outcomes, but a longer follow-up will tell us if these responses are sustained, because the good part here is that we're using a combination which is synergistic along with obinutuzumab, which has also been known to be very effective. So maybe a combination will help. This trial obviously only included patients who are enriched for high-risk features. And so we see here we expect 20 to 30% to have p53 mutations, but here we have almost 60% patient with these mutations. And look at the 3-year progression-free survival here. Even for a high-risk group, 93% patients are free of progression. So, and there were no new additional safety signals, probably because, we are dealing with safer 2nd-generation BTK inhibitors rather than combining it with ibrutinib. Another triplet trial is the BOVEN, which also included some patients with mantle cell lymphoma. And this was published in Lancet Hematology. Small numbers, 39 patients only. And it explored MRD as a biomarker for treatment discontinuation. And again, very high MRD negative rates. Time to MRD detection, undetectable MRD was 8 months. So it's less than a year of therapy to get that. And we can expect close to 90% patients who had undetectable MRD here. So the triplets give you even deeper responses. And we've seen that depth of response is equivalent to, probably equivalent to a better progression-free survival. So sustained MRD after 15 months of stopping treatment, look at this, 94%. So patients who have stopped treatment, 94% patients are still undetectable MRD in the peripheral blood. So we're not even talking about the relapse clinically. It's undetectable MRD. So these are very, very encouraging, this data is, but still really early to comment upon it. So this is a slide adapted from the classical Dr. Nitin Jain slide. And this is how we sequence today. Covalent BTK followed by BCL2 inhibitors. We can use all sorts of combinations. It's almost literally a menu card approach today. And this is how we would do it. So I would definitely choose to go ahead with a fixed duration combination because of the benefits and the prolonged progression-free survival benefit that we are getting. So moving on to the disease, which is revolutionized completely, especially in the Indian scenario, because we see a little less of CLL in India compared to the West, and also because in AML, it was such a high unmet need that we needed something. So why was it an unmet need, especially in older adults? So in the pre-Venetoclax era, this was dismal. when we see the curves in CLL, they are all here, somewhere near here at the pointer. But look at the curves here. They're so further down, it was really dismal to look at it. So the CR rates are 30-40%. The survival is less than a year. 1 year survival is like half the patients will be surviving a year. And nobody almost survives long term with just a single agent azacitidine. Very few patients would have a long-term benefit with that. So these are just bad numbers. But mind you, this trial led to approval of azacitidine. So this is the trial. But our margins for benefit were, the threshold was really low. So now what? A lot has changed. Especially look at the underside, the lower part of it. In the patients who are ineligible for intensive chemo, for all patients, we have a lot of new drugs here. And in a lot of these combinations, Venetoclax features. So if we see the journey, this part has been plagued. Look at this. No advancement for almost 20 years. This was the 7+3 era. So if you don't get it, you're probably not going to get anything else, just single agents approved in 12 and 15. But after 18 and beyond, this one has revolutionized a lot of things. Obviously, FLT3 inhibitors also have had a significant progress, but nothing as fascinating as adding Venetoclax. So this was the preclinical study on an AML cell line, which kicked off things in 2013. Look at this, the apoptosis percent with no Venetoclax, that is 0 nanomoles, versus 50 and 25 nanomoles of Venetoclax. Significant difference in apoptosis. So we know that these MOLM13 cell lines are sensitive to Venetoclax. So this is the live cell number, exactly opposite of this, more apoptosis, obviously less live cell number. So we tried monotherapy like we did in CLL initially. So it was a phase 2 trial, small numbers, very old age patients, relapse refractory patients, just a very poor overall response rate. If you remember, the CLL response rates were 70%. This is where the bullseye versus hammer strike, which I was speaking about initially, comes into play. So these cells in AML, as we know, is a genomically very complex disease. It doesn't depend on a single driver. There are a lot of other passenger mutations and a lot of other pro-survival signals. So it didn't do as well as expected. There was a subgroup identified, which was the IDH mutated. We'll speak about it a little later. But look at the abysmal duration of remission. We're just speaking about less than 2 months of remission. So when we see here, it's a big thumbs down. Leukemia-free survival, 2.5 months. Overall survival, less than 6 months. No progress. As monotherapy, it's failed for sure. So we combined it with hypomethylating agents and unleashed the revolution. So what happens is there is increased MCL1 levels, and that reduces the dependence on BCL2 that we've already seen. So if one pro-survival protein is reduced, the other one goes up and vice versa. Azacitidine, which is our hypomethylating agent, reduces the MCL1 levels, and therefore it increases the cell's dependence on BCL2 and therefore makes it more susceptible to Venetoclax. Azacitidine has also known to activate BAX, which is outside of its domain and working with BCL2. So this is something which is an additive effect, not only synergizing with Venetoclax, and it increases the apoptosis in AML cells. So the change has been evident. Again, I compiled this table using these 4 studies, and these are the 4 landmark trials that we keep quoting all the time. And look at the CR rates here, which we had with HMA monotherapy. They were close to 30%, as we saw. And then we look almost at 60 to 70% with the combination of HMAs plus Venetoclax. Again, for IDH mutated, hugely successful, much better CR rates. And even for P53 mutated patients, this seems to work, although much lesser than for the others, but it does seem to work. The good part is here that the time to respond is really short. And this is of real use in the Indian scenario. We really want to get these patients into remission because AML is a monster when left untreated. So 1 to 2 months is good. It prevents these patients from getting fungal pneumonias. It prevents these patients from a certain death. And here the time to response with monotherapy is almost up to 4 to 6 cycles. We know that classical teaching, just don't stop unless there is, wait for 6 months for response. That's not the case with these 2 agents. And also the duration of responses are doubled from 6 to almost 13 months. And the overall survival medians are also from less than 6 to 12 months. We've got almost 14 to 14.5 months here. So this is the phase 3 landmark VIAL-A trial, which we are all aware of, the amazing work done by Dr. Courtney DiNardo. And here we are speaking about IDH mutated AML in the previous slides as well. So why is there such a huge difference? There is a huge difference actually. When we see IDH1 mutated and IDH2 mutated with single agent AZA, this is the short bar here, and this huge bars are with the combination. So the combination is much, much better, and it's almost leading to a doubling of the median progression overall survival. Mind you, we are speaking into AML territory now, so it's all overall survival, not progression free here. So this here is 12 months for the wild type, and for the mutated ones, we are speaking of almost 24 months with this combination. These both arms are treated with HMA plus WEN. So HMA WEN in wild type 12 months, which is almost as equal to standard. And here it gives you 24 months, so double. Why is that so? Why are these IDH mutated AMLs so sensitive? For that, we need to, okay, so again, there are a few numbers here which I've added here. You see the forest plot, everything favors HMA Venetoclax. This is from the Dinardo paper, VIAL-A trial, everything favoring it with HMA-Ven. So IDH mutated works wonderfully well. FLT3, we know it's somewhere in between, TP53 somewhere in between, but IDH, look at the bars here, significantly favoring HMA plus Venetoclax. But why? So a little bit of the Krebs cycle we are all aware of, and that is the reason we all studied it in med school. So this 2-hydroxyglutarate, it inhibits the cytochrome C oxidase enzyme, which is a part of the electron transport chain. So because of this inhibition, the threshold for BCL2 inhibition is lowered. So in a sense, the IDH mutation is making the AML cell dependent on BCL2 for survival. And then we are giving a BCL2 inhibitor. So obviously it's going to work wonders. This cell was exquisitely dependent on BCL2 and we cut off its source. So that is the reason why these IDH mutated AML patients respond so well. So in this VIAL-A and C, the paradigm shift was apparent. We look at the overall survival from almost 10 months to 15 months. And even in the VIAL-C, which is combining it with the low dose cytosar, we see quite a significant overall survival difference. So in summary, Venetoclax is approved by the FDA at a dose of 600 milligrams with low dose ARA-C and 400 milligrams with hypomethylating agents. And the risk of TLS has been shown to be much lesser in AML compared to CLL, wherein we use weeks of ramp up versus here, we use just some days of ramp up. So on day 3, we are giving the full dose. So compared to week 5, which takes it to 400 milligrams in CLL. So that's the difference, and much lesser tumor lysis syndrome here. Although there are a few high-risk groups, like the kinase mutated ones and the ones who present usually with hyperleukocytosis, for which hydroxyurea to reduce the white cell count to less than 25,000 is recommended before initiating Venetoclax. So why not combine Venetoclax with some intensive chemotherapy? Obviously modified intensive chemotherapy, not the typical 7+3, but reduce each one by a couple of days. So 5+2 chemotherapy. We sometimes do this in our not so fit patients. So why not combine them with Venetoclax? So this was done in a phase 2 trial, and 51 patients were accrued with a median age of 72 years. And look at the response rates here. For an overall population, which included secondary AMLs as well as our de novo AMLs, the overall response rate was 72%. A lot of them were CRs. We don't have data about the MRD here. And these were the patients included. So more than 65, but fit for chemotherapy, de novo as well as secondary AML. So the primary endpoint was to find out the optimal dose schedule of Venetoclax. So multiple cohorts were used here. And this is the 50 milligram cohort. This is the 100 and then sequentially 600, which was found to be too toxic. So a 14-day total period is given, out of it 7 days pre-phase. And on day 7, we start with the cytarabine and idarubicin. Again, so the issues with this trial were quite significant here. The median time to ANC recovery is 26 days and platelet recovery is 25 days. Can get a little difficult in old patients. And look, more importantly, was the delayed platelet recovery in the subsequent cycles, the consolidation cycles which were given. So if we come back to this one, the consolidation cycles were 2+1. So 2 days of cytarabine with 1 day of idarubicin. So these were consolidation cycles into 4. So this is becoming difficult to give. This was not a typical high dose ARA-C or intermediate dose ARA-C consolidation. It was a 2+1 idarubicin included consolidation. So here the platelet recovery was quite delayed, almost 1.5 months it took. So the 600 mg cohort was completely amended, and only 400 milligram was used during consolidation. But there was a 30-day mortality was 6%, but this is in a trial population in the West, so we can expect much worse in India. So yet I don't know if anyone's using it in their day-to-day clinical practice, but definitely worth exploring. So MD Anderson went a step ahead and combined it with an even more intensive regimen of flag-idarubicin in a phase 1B, a phase 2 trial. And only one patient was refractory to this regimen. Look at the overall response rate, 97% here. And here, if we see, these numbers look stunning. This upper arm is the survival probability in newly diagnosed AML. At 12 months, we're having close to 97, 98% survival here. So it was, and they said that it was well tolerated, but can this really be replicated? I'm not sure of the Indian setting. The febrile neutropenia they reported was quite high. There was some bacteremia, pneumonia, and sepsis, which is anticipated with such prolonged cytopenias, which were almost 31 days for newly diagnosed AML and almost 37 days for a relapsed refractory population. Febrile neutropenias, 50%, bacteremia, 35%, but we have much more aggressive organisms in India. Maybe a little difficult. Surprising here was the 30-day mortality 0% and 60-day mortality of only 4.4%. Amazingly well tolerated according to them, up for exploration in India, but good numbers to look at the benefits of this in terms of efficacy. We'll speak about the safety later, but efficacy-wise, there is no question. So the practical aspects, everybody has these questions. I also have them all the time, and I try to dig very deep. So when do you push? When do you stop? This is when you push and stop. In cycle 1, definitely we must try and give the full quota of therapy, because unless there is significant, clinical judgment should dictate. But I would recommend that we try to give at least 21 to 28 days and do a bone marrow for response assessment on day 28. If there is remission, maybe we delay the next cycle definitely and give some growth factor support. But if there is no remission, which is here, then you should definitely continue the treatment and again do a bone marrow at the end of cycle 2. In all subsequent cycles, try to reduce the duration of Venetoclax rather than the dose of Venetoclax. Don't interrupt if the cytopenias are not clinically significant, and rather optimize supportive care. So these are the takeaways and the way to do it. It's easier said than done, but with good nursing care, quite achievable. So again, coming to the third malignancy for the day, higher risk MDS. Again, a bad disease. In some senses, it is almost like an acute myeloid leukemia. Monotherapy, okay, better overall survival, but just look at the survival for these patients now. High risk MDS, just 17 months, 1.5 years. And once they fail this therapy of monotherapy with azacitidine, we are looking at just palliation, just 6 months of supportive with care. That's all they get. And therefore, it was a high unmet need. Again, none other than Dr. Zedan came up with this good phase 1B study. Here, it was 7 days of AZA plus 14 days of Venetoclax, unlike in AML, where we use 28 days. And all of these patients had failed a prior HMA. So historically, we are looking at less than 6 months, mind you, from the previous slide. But here, we got a median overall survival of almost 12 months. So there's doubling of overall survival in this patient, which is very hard pressed for a good second agent. Look at the CRs, poor, but complete response, overall responses, morphological CRs, 39%. Good part of 1/3 of patients attaining transfusion independence. But again, our USP, the time to CR. So 1.4 months. So the patients go into CR much early, and that's something which really benefits patients. So based on this phase 1B data, there's a phase 3 trial which is currently accruing. I don't think the results are yet out. This is the Verona trial, a phase 3 RCT with 500 newly diagnosed high-risk MDS patients and no previous HMA or Venetoclax exposure, randomized in a 1:1 manner to Ven plus AZA versus Ven plus placebo, and continued indefinitely until disease progression, toxicity, or them undergoing transplant. And I think, we are all awaiting results of this trial as well. So what about large B-cell lymphoma? What happens here? So Venetoclax is not the magic pill that we want it to be everywhere. So we've spoken about, the glory part of Venetoclax, but it's not the same everywhere. That brings us to this classical alliance 051701 trial, wherein, we went a little too high and too deep. We hit it too hard and faced we burnt the fingers. A lot of these patients, the primary endpoint was progression-free survival, which was better, in fact. But this trial led to a huge safety signal and led to increased induction mortality because of the venetoclax. The dose here is also 600 milligrams, probably based on a phase 1 data here or some preclinical data, but which is quite high. But with RDA epoch, I don't think that venetoclax is a good option at all. And look at the curves here. So please don't add venetoclax with RDA epoch in any patient population. The double hits, triple hits, nothing works. So it's RDA epoch probably, or maybe R-CHOP, I don't know, but definitely not venetoclax with RDA epoch because of increased induction mortality. And if it happens in a trial, it's definitely going to happen in the real world for sure, and in a much worse manner is what I anticipate. We've got this again. How about with R-CHOP? RDA epoch we know is very toxic to administer, but how about R-CHOP, the standard? So this was the Cavalli trial, again a phase 2 trial, included all newly diagnosed DLBCLs, 800 milligrams dose. Don't know why. And surprisingly, 70% of patients completed treatment with venetoclax. Further tells us how good R-CHOP is. And the primary endpoint was safety here, tolerability, and the CR rates, and not a progression in overall survival, which was the secondary endpoint. And the results were compared with the R-CHOP was the O-CHOP trial, that is the Goya trial with Gazyva, obinutuzumab. And we see here that BCL2 fish positive and the double hits, the delta CR, that is the difference in CR, is quite significant by adding the venetoclax. So it is doable, and the primary endpoint is met here. Again, no major safety signals, and the 2-year progression-free survival hazard ratio favors the venetoclax addition. And if we stratify further by the BCL2 positivity by IHC, again, the hazard ratio still obviously favors venetoclax with R-CHOP. So maybe in this population, we may add. There were a lot of grade 3, grade 4 hematological toxicities, almost 90% patients, and 5 deaths were due to adverse events, but still maybe can be considered as long as, the trial did support some use and some benefit in the progression-free, and the overall survival was not different, but progression-free, there was some difference. So how about for multiple myeloma? So our special drug is only for a special subtype. We all know that, but we'll just recapitulate that myeloma with translocation 1114 is a unique subtype, and almost 1/4 of patients will have that translocation. Myeloma cells overexpress anti-apoptotic proteins, usually in a heterogeneous manner, and their dependence on BCL2 is usually variable. But for 1114 patients, the high BCL2 by BCL-XL and high BCL2 by MCL1 ratio is being shown here. So these cells are more BCL2 dependent compared to the rest. So maybe there is a rationale of using a BCL2 inhibitor specifically here. So this phase 1 study by Dr. Shaji Kumar in blood showed that this Ven monotherapy, the dose is high, it's 1200 milligrams. Further, these patients had double refractory status to BOT and LEN, and this is in 17 when we did not have these bispecifics and CAR-Ts and everything in the West as well. So 61% double refractory got venetoclax here, monotherapy. 14%, that's 20% attained a response, which is all patients put together. But there was huge differences in this arm, which is the ones with translocation 1114 on subgroup. So the overall response rate for them was almost double, 40 versus 21%, and a lot of VGPRs as well. Relatively well tolerated, we've learned to expect 30 to 40% patients having neutropenia with venetoclax. So the Bellini trial, good and the bad. So it combined when bortezomib dexa versus bortezomib dexa. Patients here were definitely not resistant to bortezomib. They had received 1 to 3 previous lines of therapy, and the dose of venetoclax was reduced here to 800 milligrams. And 291 patients with 60% having a prior transplant. But here the 13% patients who had 1114 and 80% patients had a high BCL2 expression by IHC. So we look at these two cohorts here, which are in green. These are the ones where we can probably give a green light to venetoclax. So 1114 myeloma and a high BCL2, PFS hazard ratio as well as overall survival hazard ratio is almost favoring venetoclax here. And for the patients with high risk cytogenetics and a low BCL2, it's definitely a red flag. Look at the OS 10.6 hazard ratio, 4.58. Definitely not going to be using Venetoclax here. So, and again here, 11-14 negative patients also, look at the OS, it's much worse. The PFS was better, but the OS was not. So what is the crux of Bellini? The addition of Venetoclax did increase the mortality, just like we saw in the DLBCL trials. There was early treatment emergent deaths. Again, it's a myeloma population, so it's predominantly elderly frails. And this is definitely for relapsed refractory myeloma. So we know the performance status won't be so good. The hazard ratio did improve, but this is again just semantics and just nitty-gritties here. The trend improved towards OS. Again, we're talking of trends, but in 11-14 patients, definitely a biomarker-driven use of Venetoclax can be definitely recommended, but it is not currently FDA approved for this indication. So we are not going to be able to give it if we are looking at an insurance in the West, but in India, probably for a relapsed refractory population, with 11-14 not having any other bispecific or CAR-T, this may be considered. What about ALL? So there are a lot of unanswered questions. This is new territory. So we need to identify which subtype, because I am sure not all ALLs, like all myelomas and DLBCLs, are going to respond. So we need to see what is the most BCL2 dependent and therefore then target that. What is the best strategy? How can we accommodate Venetoclax with our chemotherapeutic regimens? And what is the mechanism of resistance? How long will it work? Will it serve as a bridge to allogenic transplant? What are the things going to be? These are unanswered. This is a beautiful diagram in this paper in Cancer Discovery, wherein it says that different maturation stages have different dependence on growth factors. So here BCL2 is in ETP ALL is basically BCL2 dependent. This is the early thymic precursor, and this is your typical TALL once it has a double negative phenotype here and then the single positive ones. So BCL2 becomes BCL-XL dependent. And this dependence changes. So maybe in ETP ALL, there is some role. Anyways, we know it's quite a difficult subclass to treat. So BCL2 inhibitors have been tried in ETP ALL. There is some data case reports from India as well. Another subtype is the MLL rearranged. Again, classically a high-risk subtype, but it has been shown in preclinical models that these cells express high levels of BCL2 and they are sensitive to Venetoclax. So phase 2 study was done again by Venugopal et al. From MD Anderson. This phase 2 study had 23 patients and half of them had received post-transplant. So again, a high-risk cohort. Overall response rates, amazing, 65%. And this is with their homegrown mini CVD regimen combining with Venetoclax. So we've omitted the anthracycline here. And the progression-free and overall survival are both less than a year here. But this is a relapsed refractory population post-allo transplant as well. So there is some encouraging data in ALL, but we need to further uncover the subtype which will benefit the most. But it's finally not all rosy. Every drug which acts also creates some resistance. Every cell wants to live and will find a way to survive. There are certain metabolic changes which lead to resistance. Then there is this BCL2 point mutation that we are all aware of, the G101, but there are a lot more, something like how the TKIs evade in CML as well. Then we've got some marrow microenvironment mediated changes, some altered mitochondrial structure, because this is the site of action. So the mitochondria itself adapts. Then we've got further accumulation of P53 deletion and a loss of stabilization of the genome. And we've got changes in the anti-apoptotic dependence. So the cell which was initially BCL2 dependent will now learn to live with BCL-XL, MCL1, or some other alternative ones. So let's speak of the first one in brief. These changes in the electron transport chain alter the sensitivity to Venetoclax. And we classically know that cancer cells use the Warburg effect, but that view has been challenged. So they switch between aerobic glycolysis and OXPHOS, that is oxidative phosphorylation. And it is this upregulation of oxidative phosphorylation that can lead to Venetoclax resistance. The second is the classical mutation here, the glycine to valine. We know that the valine is a much bulkier molecule, and that leads to just a mechanical steric hindrance. So this is typical to the T315I and all these other mutations we see when treating in CML. So this is the G101 glycine to valine mutation, which happens in exon 2, and it significantly reduces the ability of Venetoclax to bind at this site. Then we have some marrow microenvironment changes, that is non-cell autonomous, CD40 ligand, LIN, and IL-6. These are these substrates which increase or upregulate the BCL-XL and MCL1 and cause resistance to venetoclax. So BCL2 is inhibited by our venetoclax, but BCL-XL and MCL1 will be upregulated by the CD40 ligand. So it gives the cell an alternate pathway to survive. Again, altered mitochondrial structure was beautifully studied. I learned a lot reading this paper. And mitochondrial morphology was studied here using transmission electron microscopy. And they showed that when resistant cells versus when sensitive cells, in the resistant cells, the mitochondria enlarged and their cristae tightened. So the ability to leak out cytochrome C was reduced. So the mitochondria learned to survive. And the mitochondrial protein, OPA1, that is the one which prevents the release of the cytochrome from inside here. The resistant cells had higher levels of this protein. So it prevented the release of cytochrome C and further activation of downstream caspases. So this is quite interesting. Then this is something which we are familiar with. If you inhibit this, something else will keep driving it, like in ETP-ALL, which is classically BCL2 dependent, but it can switch dependence to BCL-XL as well. So how do we move forward? We need to tackle this resistance. Maybe we combine it with a few drugs. So BCL2 inhibitors along with BCL-XL inhibitors like Venetoclax can be an option. We know that OXPHOS is increasing, is leading to resistance. So maybe we inhibit the OXPHOS. We know that mitochondrial structure is getting altered and OPA is getting upregulated. So we can reduce OPA by inhibiting it. And we can induce a mutation in BCL2, which will negate the effect of glycine 101 mutation. So that is GLU152 alanine. That can negate the effect of this, the reduced binding which is happening because of this mutation. This will be negated. So there are a few things in the pipeline, which is something which I cannot cover with limited time. I would love to, but this is a few key points. Orally administered drug at these standard doses. CLL, slow ramp up, really required. AML, maybe a little less ramp up. Metabolism, excretion in feces, and 99.9%, and also CYP3A4 metabolism in the liver. Again, no significant dose adjustment required for renal or liver injury, except in severe liver injury, wherein you might want to reduce the dose to 50%. And then what are the predictors of poor responses? We know that there are these P53 still has not completely gone out of the picture. This is a monster which still hides. A complex cytogenetics again. And we've been using it off-label in multiple places. I mean, I don't even have space to enlist the others. There are a lot of places where off-label use is being done, even in Indian settings. And these are some ongoing phase 3 trials with Venetoclax. Altogether, I identified close to 210 trials which are using Venetoclax in some or the other way. But these are some trials which I have shortlisted and I'm looking forward to. So some in AML, some in CLL. And these are the AML trials here, some in the maintenance setting, some in the upfront setting. A lot of things are going on with Venetoclax. So I really thank you for the attention, and I hope it was a good talk, and I'll be open for questions if MB Agarwal sir permits.
Thank you so much, Nihal. That was fantastic. You really updated all of us and gave so much of knowledge in this field.
So
very hard work and beautiful delivery.
Thank you, sir.
Let's have our discussions. Please use your raise hand sign. You can open your videos. Let's have an interactive session. Is there anything in the chat box in the meanwhile? So, have we arrived, or is there further scope for research? What are the probable strategies we could adopt to make Ven financially viable in India? Is the question by Dr. Ravi Kiran.
Right, sir. So it's I don't think that we ever truly arrive and there is never a scope for further research. There is always going to be scope for further research. The more questions we answer, the more questions we create is what I have learned over the past couple of years in hematology, and also from stalwarts like Agarwal sir's talks. But definitely there is a scope for a lot of research. In Indian scenario, to make it financially more viable, I mean, one thing which we are using is the dependence of Venetoclax on CYP3A4. So that reduces the cost by 1/4 straight away. So you combine it with posaconazole, and you're reducing it to 100 milligrams. We have generics of posaconazole and voriconazole, which are working well. So that's one way in which the cost can be reduced. Still, we do not have any generics available in India, which are definitely not from India. They are coming from neighboring countries that we are all aware. And the AbbVie molecule is still out of reach for most patients, but that should improve with time.
Thank you. Dr. Yogalakshmi, your question.
It was an excellent lecture and very extensively covered. And I'm having two queries. What is your experience of Venetoclax in pediatric AML?
Okay. Ma'am, I am an adult physician, so I don't really treat a lot of pediatric AMLs now, but in my definitely treated during my pediatric rotation days in DM. Again, not approved. There's not enough data to suggest that we might be able to use it. We did use it in a couple of patients in the CML lymphoid and myeloid blast crisis as well, with some reasonable outcomes. But I don't have any long-term data available. Definitely should be worth looking into.
Okay, sir. Sir, considering the low CR and MRD rates, MRD negativity rates in ETP ALL, should we consider adding Venetoclax to the upfront chemotherapy?
Definitely
induction.
Yeah, see, definitely may be recommended in the future. As of today, like every drug, it moves from the relapse refractory setting into the front line. Maybe, with a lack of options available for ETP ALL, we must look into combining it, but there is no data, as I would say. I couldn't find anything for the upfront setting, even from India.
Okay, sir. Okay, sir. Thank you.
Thank you, Dr. Pujita.
Good afternoon, everybody. Hi, Nihar. As expected from you, it was a wonderful talk. I have two questions. One is one on a theoretical concept of Venetoclax. As you mentioned earlier, in the mechanism of action of Venetoclax, it inhibits BCL-XL, so it has side effects of thrombocytopenia also. But if you look into the treatment paradigm of myelofibrosis, Venetoclax is more advocated than Venetoclax. Any thoughts on this, Nihar?
Pujita, I spoke about this to a couple of my friends as well. Who are doing good work in the myeloproliferative neoplasm space. I couldn't really decipher. It's a great question, Pujita. If some seniors here can answer this, this is something which has also stumped me. I'm sorry, I don't have the answer to your question, Pujita.
Okay. And coming to the next question, just a practical one. As you mentioned in some slide, like we will make modifications in the number of days of Venetoclax with the patient rather than the dosing. So at what point you will decide on making the changes after documenting the remission in the patient?
Right. Okay, so once you have maybe a remission in cycle 1 and you are moving on to the cycle 2 after giving growth factor support and all, in cycle 2, maybe we try to give 28 days. And if the patient is developing recurrent grade 3, grade 4 cytopenias, which are clinically significant, maybe we look into giving growth factors. And further in the third cycle, I would definitely reduce the dose from 21 to maybe 14 days. And even now there was some abstract at AS 23, which looked at 7+7, I believe. So even with doses as less as 7 days, duration as less as 7 days, there has been no loss of efficacy. So that is something which should be looked into in the second and third cycles rather than subjecting these patients to recurrent cytopenias and the complications which would happen, especially in India. So maybe I've tried a couple of my own patients on 7+7 after remission. And with almost 4 to 5 cycles, they and did an MRD as well for a couple of them. They're still undetectable MRD. So quite encouraging. Maybe we should collaborate and club together the data.
True. I think HCC is doing a data on that. I'm not sure. I don't know full details. Right. And one more question, Nihar. Any data on the maintenance therapy with Venetoclax in the AML patients?
No. So the phase 3 trial is still accruing. There is some early phase data which suggests that there is good tolerability in these patients, combining it with the oral AZA. But I'm not aware of the phase 3 data is, I think, not yet out. The VIALM is still accruing.
Yeah. Thank you.
Thanks. Ramesh.
It was a fantastic presentation here. I have a question, like for core binding factor AMLs, for a fit patient, you have given decibel venetoclax since the patient was having some onboard infections of fungal pneumonia, and the patient has achieved an MRD negative status. And the patient has got a favorable cytogenetics. Would you straight away go into consolidation, or you always have this thought that you have not given intensive chemo for this patient? So you would bridge by giving intensive 7+3 for one cycle and then go for consolidation.
As far as I've read, there are two takes on this. Some say that exposure to intensive chemotherapy is definitely required for these core binding factor patients. But again, most trials will never include these patients because core binding factor, we all know by standard run of the mill, they need 7+3+ GO if available for the best overall survival. But I wouldn't say, see, the final goal is to get an MRD negativity. You get it via the highway approach or you get it via the state approach. It doesn't really matter, according to me. Finally, I would look into consolidating these patients with the 4 cycles of cytarabine that we are recommending and should be done with it. But I'm up to opinions because again, I don't think there is data to say that this approach should be favored over the other. But as long as the patient has attained an undetectable MRD and at a significant depth, maybe we can look at just consolidating rather than re-exposing these patients just because they have gotten fit to anthracycline-based therapy. That would be my approach.
Thank you.
Thank you.
Thank you. Dr. Rajkumar?
Yes, sir. The Venetoclax is associated with deeper emissions and deeper molecular emissions associated with the undetectable MRDs, but certain subset of the patients do labs. What is there any data on the role of rechanneling the same drug, Venetoclax, down the line?
Yes, sir. So quite interesting question because we've seen that in the Murano as well. In the sub-study, they did allow rechallenge of these patients and they did attain a similar degree of response that they did to the initial exposure. So there is now 2 schools of thoughts, especially in this TP53, how to deal with those patients because they are supposed to have lesser duration of responses. So maybe continuous BTK versus give R-venetoclax, stop once they respond, re-challenge with R-venetoclax. Still the patient gets a treatment-free remission in between. So there is definitely data even from the Murano which says that re-challenge is feasible. I showed a bit of that in the 7-year follow-up slide as well, that re-challenge is feasible. I couldn't get into the details of that, but I'll be happy to share. There were some additional sites which were created. I'll share that with you, sir.
The TLS rates, with your personal experience, the TLS rates is a manageable, sir, with the dose escalations over a week, or do you do in a days, or what is the strategy to mitigate the TLS?
So are we looking at respect to CLL or AML? CLL. So definitely CLL, I don't start at 20 at all. I start with 50 to be honest. It's 50 for a week, followed by 100 for a couple of weeks, and then 200 and then 400. But definitely, sir, I do not do it quicker than 4 to 5 weeks. Definitely not quicker than that. I've not seen a clinical TLS using that approach, but I've not used a different approach at all because it's so vehemently recommended now that there's no point in using something lesser. And we get 100 milligram tablet, so 50 is easier to do rather than the 20s and 75. So 50, 100, 200 and 400 is what I do. And in AML, sir, as I said, not much of TLS seen, so it's just over 3 days. I don't introduce posaconazole for the first 2 days, so it makes it 100, 100, and then with posaconazole, so 100 becomes effectively 400.
Usage of respiratory so prophylaxis on high risk subsets?
Not in CLL, not in AML, sir. I haven't had the need to use it, sir.
Any data on the incidence of AMPNs?
Sorry, sir?
The incidence of AMPNs, myeloid neoplasms, the usage of Venetoclax?
Not aware of the data, sir.
Thank you.
Thank you, sir.
Thank you, Dr. Yashwant.
Sir, how was your experience with voriconazole and venetoclax 100 mg, and how was the tolerance for patients, and what were side effects with this?
Okay. So sorry if I didn't get your question right. The tolerance of patients using venetoclax 100 with voriconazole as therapy.
Yes.
Right, sir. So
Yes.
I don't think there has been any significant additional side effects that have been noted. The efficacy also, there is now some data which says that there is some difference in the platelet recovery is increased. The time to platelet recovery increases while using the two in combination, but the time to neutrophil recovery doesn't increase with the combination. So there is some data, I believe, I think it's from Israel, I'm not really sure, which used the two of them when used with combination with azoles in AML. The duration of neutropenia was somewhere around 37 days, and the duration of thrombocytopenia increased from 21 days, which was without the azoles, with 29 days with the azoles. So thrombocytopenia takes some time, which has been also our experience, but the data says that there's no difference in the neutropenia incidence. So tolerance wise, quite okay.
Yashwant, anything more? Thank you, Dr. Yeah, go ahead. Go ahead, Yashwant.
And sir, to start venetoclax initially in full dose in our patient, or like full duration of 28 days, or first to check, because we are generally not using that innovator one.
Yeah, sir, to answer that, definitely going for 28 days with any of the molecules, especially in cycle 1, because that's where the data is, and it's definitely recommended to try to get these patients into remission as soon as possible. Unless there is significant grade 3-4 toxicity, impending sepsis with shock or something, I try to push for 28 days, especially in cycle 1. With cycle 2, if the patient is in remission, definitely not more than 21 days has been the go-to now, sir. No point pushing for 28 days. And I'm sure that gradually there'll be more and more data accrued for lesser duration of venetoclax post-remission documentation.
Thank you.
Okay. Dinesh?
Excellent talk.
Thank you, sir.
Considering after CLL, like mantle cell lymphoma is like sensitive to venetoclax. So are we heading towards the oral regimen, especially in the elderly mantle cell lymphoma patients in the frontline setting, considering the very good response as well as more than 50% undetectable MRD in like venetoclax ibrutinib in sympathetic trial?
Right, sir. So definitely, maybe venetoclax will creep in there as well. There is good data, but not as robust as CLL, but definitely worth looking into in the mantle cell population as well. I couldn't cover it in the given amount of time. That was one of the malignancies that got left out. I wanted to highlight the negatives in DLBCL as well. But your question is extremely valid, sir. We do have a good rationale to use it, sir.
Yeah, thank you.
Right.
You, Dr. Sanjeev?
Good afternoon, Nihar. Excellent
Good afternoon, sir.
presentation as usual.
Thank you. Sir.
When to say a patient having venetoclax failure?
Okay. So this is a little difficult because there is no standard definition for that in the AML space. Definitely after cycle 1, we cannot say that it's not there. We need to push for cycle 2, maybe, but after cycle 3, if we still don't have any sort of response, or we have still only got morphological leukemia-free survival, we might look into alternate strategies. Especially happens in this the FLT3 mutated patients and all these others which are not so sensitive to venetoclax, the kinase dependent ones. In those, maybe cycle 3, sir, because with single agent HMA, we are saying cycle 6. With venetoclax, we don't have that kind of clear definition, but 2 to 3 is worth pushing, beyond which it looks a little difficult.
Thank you, Nihal.
Thank you, sir.
Thank you. Our colleague from Myanmar, YM.
So thank you for the excellent talk. My question is whether or not you consider dosage adjustment in first infection or AML with cytopenia and infection.
Yeah. So do you mean during induction, that is cycle 1 of induction?
Yes, sir. With severe infection and cytopenia.
Okay, so if there is grade 4 neutropenia or grade 4 thrombocytopenia, which is worrisome, then probably not dose reduction, but maybe a temporary cessation would be recommended. I do not typically dose reduce. When I give it at the full dose, or I reduce the duration or completely arrest therapy with that for the time being till there is improvement in the counts or the clinical status of the patient. So dose reduction is something which is not really recommended in AML.
Yes. Thank you, sir.
Thank you. Aniket?
Good afternoon, sir. Good afternoon, Yas. Excellent talk. It was a wonderful presentation. I have a question related to the AMLs. Now, with the advent of IDH1 and IDH2, would that be wise to add on with when
Triplet.
as well? It would be a double. It like we will be targeting the IDH or helping that or improving the response.
I think there was a talk by Dr. Davar last evening itself at Lajola, and I think Fadi Haddad covered that well. Maybe there is definitely a potential in that. Obviously, I don't have the data for that yet. Maybe the experts in the field will combine the three, and then we'll just have some more data. But seems promising. But again, how much more are we adding? So we'll really have to be looking more at the side effect profile rather than the efficacy, because the efficacy again is quite good when it comes to HMA plus Ven as a doublet in this frail population. So adding a third drug with the entire differentiation syndrome and all, really, how much are we adding on? We really need to know that.
No, I mean, the reason is because it still becomes into the high risk one. So whether can that be something which would not go on to transplant? So if we add on that as a triplet, so that is something
yeah, I mean, that should be quite a good question to answer, but I am not aware of that. Maybe we get these data in some time.
Second question is related to mantle, like adding that with the current treatment regimens. Will that, especially in the high risk populations of mantles or the high risk class, where we go on to auto as a consolidation, whether that would circumvent that as a requirement?
We have data with ibrutinib.
Yeah, we have data with ibrutinib, but
no,
because ibrutinib is it goes on and on. It's not
yeah.
limited therapy.
Time limited venetoclax. Can that abrogate transplants? If you are aware of anything, I mean.
No, I'm not aware of anything. There's ongoing.
Yeah, exactly. I'm not aware. Sorry.
Okay, thank you.
Thank you.
Question from Dr. Radhika. Which young fit myeloid neoplasm will you use Venetoclax based therapy for AML?
Okay. So this is really interesting and a very practical question. We all do that, but we don't admit it because the approvals are in the high risk patients. But someone with very bad cytogenetics, someone with a TP53, someone with maybe someone I want to transition onto a transplant, I'm sure of that. And it seems like a fit candidate for for therapy intensive, but bad outcomes we know with intensive chemotherapy for some of these high risk mutations. So in those, maybe I can definitely recommend that we go for HMA plus venetoclax and followed by a consolidation with transplant. But again, all said and done, we don't have data for that. And why not then combine for a fit patient based on the caveat approach, the 5+2 plus Ven or FLAG-IDA plus Ven. So I would still consider intensive chemotherapy if the patient is fit, maybe with a venetoclax add-on, followed by consolidation with a transplant in a high-risk population.
Thank you. There are a couple of questions related to post-venetoclax prolonged cytopenia. How do you manage?
Again, sir, the setting would differ. If it's prolonged cytopenias are what we are seeing usually with the AMLs when we treat them. And so growth factor support, liberal growth factor support if the patient is in remission, that would be one way to manage. Maybe granulocyte transfusions is as and when required. Again, cannot really highly recommend because of not really good outcomes with everyone. But those are the ways. And the best would be to manage it in a way that the cytopenias are limited in duration by reducing the dose of venetoclax and knowing when to stop. But once the cytopenias develop, you really have just growth factor support and good nursing care and maybe a granulocyte transfusion to help you.
Thank you. Aniket, you have a raised hand sign. Another question?
Yeah. Good afternoon. Okay. What is there any data of using when in the low grade, like the marginal zones, in the splenic marginal zone or folliculars, where all at what line would you add them in?
folliculars, surprisingly, despite it being the first place where BCL2 was uncovered, there is really poor responses to Venetoclax. Somehow it's just not working well. So in our scenario, fortunately, we see much less of follicular than in the West. And I would consider it probably nothing before the second or third line, because rechallenging with chemotherapy, except for the POD24 population, that is the high risk one and the difficult to treat. But other than that, rechallenging still works. So I would not even look at the second line or the third line setting. Beyond that, probably maybe when combinations. But for marginal zone, really, I'm not aware. It again works quite well, not that difficult to treat a population. And definitely for follicular, I'm aware that it should not be before a second or third line. And in the West, I think that question will never be answered with more and more drugs available now.
And in any role of maintenance of when post-transplant, especially post-allo or post-allo, where we are having a high risk for a complex karyotype or monosomal karyotype patient, we know that the transplant outcome is still going to be not that good. So in such population can then help to, especially if the MRD becomes positive post and all.
Maybe in these cases with MRD positivity, despite tapering immunosuppression rapidly, maybe we think of a DLI or something, but oral AZA with Ven trial will give us some more data, I guess, because oral AZA alone, as we know, is still not that great. Tolerance is also bad with the GI disturbances and all, but maybe oral AZA plus Ven might answer that. Not sure of any phase 1 or phase 2 yet.
Thank you.
I'll look into that.
Thank you. One last question from the chat box is related to, besides tumor lysis syndrome and cytopenia, is there any other toxicity to be bothered about?
Sorry, sir.
Besides cytopenia and tumor lysis syndrome, is there any other toxicity that has to be looked at?
No, I would predominantly say that the cytopenia is the most worrisome. Tumor lysis is also not that worrisome a toxicity. It's about us learning to manage the when cytopenias better that will lead to betterment. I mean, there are diarrheas and GI disturbances which are reported in 30-40% patients all across trials, but they seem to be well managed with conservative approaches. Doesn't really need much of clinical interruptions because of, or when reductions because of those I have not seen. It's predominantly the cytopenias and the problems with the cytopenias which cause complications with Ven.
Thank you, Nihar. That's the last question we have. We have Sumit for the vote of thanks. Sumit, over to you.
Thank you, Dr. Nihar Desai, for sparing your valuable time. It was a wonderful presentation, and you have given a 360-degree view of Venetoclax from both bedside as well as bedside. The amount of effort that you have put in to make this presentation and to collate all the data was quite evident. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal sir, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank our chief guest, Dr. Chapse Philip, all the discussants and participants who have joined us for this live webinar. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. So thank you to them as well. Thank you so much, everybody, and have a wonderful Sunday.
Thank you, Sumit, for supporting our academics. And one last word, Nihar, it was wonderful. Keep it up. You are genius.
Okay. Thank you so much, sir. Thank you, sir. Thank you for the opportunities.
Bye.
Thank you.